That looks good.
Excellent. Well, those were two excellent and I would say really very visionary talks. And so for the last half hour, we're just going to return to the clinic and address the case of this very nice 54-year-old man who came to me complaining of leg pain and weakness of 5 years duration. And so in 1996, this gentleman was diagnosed HIV positive and he started antiretroviral therapy at that time. In 2012, sometime later, he began to complain of rib pain, and it was clear from the chart that there was really no diagnosis, nothing found on workup. Between 2013 and 2014, he saw numerous specialists for foot and leg pains. He was initially treated for gout. One physical exam describes him as walking with a wide gait with some tibial bowing and also having significant muscle wasting. He was sent for an EMG, which showed a questionable polyneuropathy, and plain films were obtained showing that he had tibial plateau and navicular insufficiency fractures, which were attributed at that time to osteoporosis. He was sent to podiatry, to neurosurgery, to orthopedics. He was given orthotics and he was given physical therapy, all without much change in his clinical condition. By 2017 to 2018, he was really in unbearable pain and needing opiates and having trouble walking. He was sent to vascular surgery after a duplex showed significant peripheral arterial disease, and thereafter he underwent angioplasty, tibial bypass grafting, fen-pop bypass grafting. His pain did not resolve, and he progressed to a motorized wheelchair. And at that point, a study was obtained. This is a study that he had, and for those or many of us that probably aren't familiar with this is a technetium-99 bone scan. On the left side are kind of more lighter images and on the right are more pronounced images. And you can see a fair amount of abnormalities here, both in the ribs. These are darker than they're supposed to be. These are darker than they're supposed to be. And this is definitely darker than it's supposed to be. And this is how it was read by our nuclear medicine docs as near symmetric increased radiotracer activity in the bilateral lesser trochanters, multiple bilateral ribs, bilateral SI joints. The pattern of distribution of these lesions favors possible insufficiency fractures rather than a malignant osseous process. And in particular, when you see dots in a line like this, it's more favorable for a fracture. In terms of the ankle, abnormal increased radiotracer activity in the left ankle and left foot could be secondary to a complex regional pain syndrome. That's because bone scans light up in areas where there's just increased blood flow as well, where the tracer accumulates more. So at that point, his creatinine was 1.05, and I should say that it stayed in the near normal range for much of the time we were taking care of him. And so it didn't really fit to explore whether this was renal osteodystrophy. And instead, his doctor at the time wondered whether he could have osteoporosis or possibly osteomalacia after reviewing the films with nuclear medicine. Well, what's the difference between osteoporosis and osteomalacia? Well, first of all, one very big difference is symptoms. So osteoporosis is usually asymptomatic until you break something, whereas osteomalacia is not asymptomatic. So this is a condition where you can have dull, aching bone pain that can be quite severe. You can progress to having weak muscles and finally somewhat of a waddling gait, as was described some years prior for this patient. The other obvious difference is that patients with osteoporosis do not usually have abnormal labs, whereas in osteomalacia, labs are usually abnormal. So let's take a little bit more of a trip away from renal osteodystrophy and looking at osteoporosis. It really means porous or brittle bones. But in osteoporosis, the ratio of mineral to bones is actually normal. So you're not having mineralization problems. The main problem is that the osteoclasts are outpacing the osteoblasts. And how does this look? And I got to say, in preparing for this talk, I thought glomerular pathology was complicated, but I was just wrong. So compared to bone pathology, we have it easy. So this here is bone in blue, and the blue stuff is mineralized bone. The small red areas are osteoid or unmineralized bone, and in between is the bone marrow. This is normal, and on the right is osteoporosis. So what you're seeing is basically just not a lot of good bone, big holes in between bone. But the amount of bone to osteoid, it's a bit hard to see how much red is here. It's pretty similar between accounting for the total amount of bone. The ratio is about the same. Osteomalacia, in contrast, means soft bones. And it refers to a failure of mineralization. And the best way to look at that is at a closer picture. This is mineralized bone shown in blue, and then the osteoid, which is unmineralized, is shown here in red. And you can see that there's vast amount of unmineralized bone compared to mineralized. When we look at normal bone up here, most is blue and small amounts are red. In osteomalacia, the vast majority is unmineralized, and all these little dots are osteoblasts kind of trying to do what they can, but not able to perform properly because they don't have enough minerals to do so. This is very close to our patient's x-ray, which did not translate to PowerPoint and Zoom as well as I wanted. So I found one that looked quite a lot like it, but it demonstrates what are called looser zones, which are a classic feature of osteomalacia. They're not specific for osteomalacia, but very classic. And these are these little dark lines, and they're essentially perpendicular to the bone. They represent what are called pseudo fractures, or areas of unmineralized bone. And our patient had definite looser zones on x-rays as well. And so the diagnosis of osteomalacia was made essentially based on x-ray, bone scan, and his clinical history of significant bone pain and worsening weakness. Well, what are the causes of osteomalacia? You know, we used to in the far distant past, see osteomalacia at times in dialysis patients on bone biopsy, although it's quite rare. But it's not rare worldwide. So worldwide, vitamin D deficiency is by far the most common cause of osteomalacia. In some populations, dietary calcium deficiency can cause it. Hypophosphatemia is a cause, and anti-epileptic drugs through various mechanisms, including interfering with vitamin D metabolism, are known to cause significant osteomalacia as well. So let's go to our patient's labs. So first, he had a vitamin D level sent by his PCP, and that was completely normal. His calcium came back completely normal, and his phosphorus came back at 1. And at that point, he was sent to kidney clinic at Harborview. So here was his first day at kidney clinic at Harborview. His past medical history was notable for B3 HIV. That was due to low CD4 count, but no HIV defining illness. He had a very heavy smoking history. He had mild hypertension, and as we stated, peripheral vascular disease. Here are his medications in alphabetical order: aspirin, atorvastatin, darunavir, dolutegravir, emtricitabine, which probably not many of you are familiar with, but they're all HIV medications: gabapentin, morphine, ritonavir, another protease inhibitor that's a booster in HIV, and trazodone for sleep. On exam, he was extremely frail, relatively normal vital signs, sat in a motorized wheelchair. He had no icterus, no thrush or lymphadenopathy. His cardiovascular exam was normal. His extremities had significant sarcopenia. He had no edema. And his labs the day we first saw him in kidney clinic included a sodium of 136, potassium 3.1, bicarbonate 22, creatinine 1.05, calcium 9.3, phosphorus 1.7, and a PTH level had been sent a week prior and come back at 21. So I think it's fair to say that we all live in the land of hyperphosphatemia. We rarely venture into the land of hypophosphatemia, and so we will today. And just to do that, let's just go over the daily phosphorus metabolism briefly. So each day we eat about 1,400 milligrams of phosphorus. And if you're a big cheese eater like me, it's probably a lot more. We absorb through our intestines about 900 milligrams, and we put out in our poop about 500. And during the day, there's a fair amount of exchange between intracellular and extracellular phosphorus. At the level of the kidney, our hardworking organ filters 7,000 milligrams a day, reabsorbs 6,100, and therefore puts out that 900 that was initially absorbed into our body to keep us in beautiful metabolic balance. So So at each step of this process, things can obviously get messed up. And these are the common causes of hypophosphatemia, depending on where we start. If we think about decreased intestinal absorption, that can happen in settings of malnutrition. Before we had H2 blockers and PPIs, people took massive amounts of Maalox and Mylanta for GI complaints. And so this hypophosphatemia could be seen in patients just due to using phosphate binding agents like Maalox and Mylanta, for people that don't know, contain both aluminum and magnesium. Both have potent phosphate binding capacity. Vitamin D deficiency, secretory diarrhea, and GI losses of other sorts. In the hospital, internal redistribution of phosphorus is one of the most common causes of hypophosphatemia. That can happen from anything that accelerates intracellular glycolysis, including respiratory alkalosis, recovery from malnutrition, which we think about as something called refeeding syndrome, recovery from diabetic ketoacidosis, and certainly in situations of rapid cell uptake or proliferation and following parathyroidectomy, such as hungry bone syndrome. And then finally, our organ, what I think is the smartest organ in the body, the kidney. We're familiar with renal loss of phosphorus in settings such as tubular disorder, malignancy-induced hypophosphatemia, which we'll touch on in a minute, and then hyperparathyroidism and PTHRP, which is on every list and I have actually never seen in my life. So we decided to simplify this list with the resident that I was seeing in clinic that day who saw the patient. And much as we can do for magnesium and potassium and many electrolytes, I usually tell the house staff that it's usually either shift, it's the gut's fault, or it's the kidney's fault. And so we stepped back and we figured that if this guy actually had osteomalacia based on his low phosphorus, it probably was something that was going on for quite some time, that the phosphorus needed to be low for a while. So it was unlikely that this was just due to shift and respiratory alkalosis, refeeding, even though he looked quite thin, and rapid cell growth seemed unlikely. In terms of the gut's fault, we already had a vitamin D level, and so vitamin D deficiency seemed unlikely. When I was preparing for this talk, I was actually fairly surprised to find that 125 vitamin D did not actually play a huge role in phosphorus absorption from the gut. So I always thought that vitamin D deficiency caused low phosphorus because of gut absorption. But it turns out that what happens with vitamin D deficiency is that you don't absorb as much calcium in the gut. And the hypocalcemia stimulates hyperparathyroidism that then causes renal wasting of phosphorus. So the hypophosphatemia from vitamin D deficiency is not the gut's fault, it's actually the kidney's fault, okay? We saw that he was malnourished. We considered whether that was purely a problem of his not eating enough phosphorus. He was not taking antacids, and there was no diarrheal history to suggest malabsorption. And the final question was whether it could be the kidney's fault. We knew his parathyroid hormone was normal. The other two things we thought were in the differential, given the enormity of his bone changes and his history, were whether he could have excess phosphatonins, such as FGF23, or whether in fact he had tubular defects such as Fanconi syndrome. And so we sat there and said, well, really, is this the gut or the kidney that's causing the phosphorus problem? And we're very lucky to have the urine to look at in that situation. And so when we want to know whether it's the kidney's fault, the easiest thing we can do is look at the urine. And in this case, we had at our disposal a fractional excretion of phosphorus, which we got back the next day. And fractional excretion of phosphorus is basically the same calculation we do for the fractional excretion of most everything. Urine, I'm not even going to spell it out. You guys can see what it looks like. So the important teaching point here is that the fractional excretion of phosphorus should be less than 5% if the hypophosphatemia is not due to the kidney's fault. So if the kidney's behaving properly, PFOS should be less than 5%, okay? And so anyone want to guess what our patient's PFOS was? Well, we're on Zoom, unfortunately. So it was 36%. So that was high. And so at that point, we said, all right, well, this was definitely the kidney's fault. And we went back and we said, well, his parathyroid hormone is normal. So this is either a problem with excess phosphatonins or with tubular defects such as Fanconi syndrome. So what am I talking about when I say excess phosphatonins? So I'm talking about the syndrome called oncogenic osteomalacia, which some of you may be familiar with. It's a paraneoplastic syndrome in which small mesenchymal tumors, usually made out of sort of mixed connective tissue disease, they actually secrete FGF23 and at times other phosphatonins. These are usually, they're not always, but they're generally benign tumors. They can grow locally and cause space occupying lesions. Probably the hardest thing about them is that you can't find them. They can be found anywhere from head to toe. 90% of them are in bones and soft tissue, and they can be very small but very active. One way to find them is by nuclear medicine scan or PET scan. Oopsie, I'm not going to show you those yet. So and this is a PET scan using somatostatins. Some of these have neuroendocrine origin, and it shows a pretty tiny tumor in a vertebral body. So the characteristics of these tumors are that they actually secrete FGF23. As we know, FGF23 inhibits 125 hydroxylase. So these patients will have high FGF23 and low 125 vitamin D as a result. And the way to treat them is to take out the tumor if you can, and if it's in a surgically accessible site, or to use a new FDA approved anti-VEGF antibody called burosumab. And so we thought, well, we ought to look at this. You know, this guy doesn't look too healthy. And so, so we sent these levels, and indeed his FGF23 level came back normal, and his 125 vitamin D level came back elevated, which was essentially the opposite of what we would expect in someone with an FGF secreting tumor. And at that point we said, aha, he has tubular defects and it is Fanconi syndrome. Anyone have any questions before I go on? Okay.
I had a question whether or not he received any phos supplementation or IV phos before you evaluated him.
Yeah, he very good question. So he did receive phos supplementation between when the PCP received the phosphorus of 1 and when it was 1.7 on the day he saw us. He had been put on some sodium phos supplementation. So, but only a few days before. So he hadn't gotten very much. So. All right. Well, when we think about the proximal tubule, I think that Mike just gave a very, very sophisticated talk at the, at the cellular and proteomics level of what the proximal tubule is doing. As nephrologists, we know that it's a very busy place. Just to give you an example, this is just the metabolism of uric acid in the proximal tubule. So, and the number of transporters that are involved in uric acid, reabsorption and uric acid secretion are this complex. When we think about Fanconi syndrome, the first 4 here, normal glycemic glucosuria, aminoaciduria, bicarbonate wasting with a type 2 RTA resulting, and phosphate wasting are what we think about as most common, but many other things can be lost in severe Fanconi syndrome. What does this mean for the patient? So if we look at the manifestations and clinical consequences of proximal tubule dysfunction, the hypophosphatemia can be the most severe. It can lead in children, for instance, with lead nephropathy to have rickets, and in adults to developing osteomalacia. The type 2 RTA can lead to acidosis, which can further impair bone formation. The hypokalemia can lead to concentrating defects. Salt wasting can lead to dehydration. Children with Fanconi syndrome commonly present with dehydration. Interestingly, the way we make the diagnosis is most often looking for normal glycemic glucosuria, but that usually has no clinical consequences whatsoever. So we took a look back sitting in the clinic room at this patient's labs, and we noticed that since 2017, when we could find the earliest urine dipstick, he had had very pronounced glucosuria with completely normal serum sugars, blood work showing normal sugars. So he was definitely having inappropriate wasting of phosphorus as well as glucosuria. And then sadly, we looked back at his blood work, which at that point was about 5.5 years ago. And we found that even 5.5 years ago, his phosphorus had been noted to be low at 2.2. As well, he had hypouricemia, which is a feature of Fanconi syndrome. We don't think about that much. So when they were evaluating him for gout, he had a very low uric acid, which would have been a tip-off at that time. When we think about Fanconi syndrome, I usually think about the differential as being what I call the 4 M's, which are metabolic conditions, heavy metals, medications, and myeloma. In terms of metabolic conditions, these are primarily inherited conditions. So remember that Fanconi first described Fanconi syndrome among children with cystinosis. Dense disease, Hartnup disease, and Lowe syndrome are also associated with Fanconi syndrome as well. Among heavy metals, lead, cadmium, and mercury can be associated with Fanconi syndrome. And patients that work in factories with lead and cadmium, usually they're checked for low molecular weight proteinuria to screen for early tubular problems. Medications such as antivirals, chemo, and antibiotics can cause Fanconi syndrome. And finally, we're all familiar with the proximal tubulopathy that can be a feature of myeloma or monoclonal gammopathy of renal significance. Well, where are these various diseases doing their damage? If we look at some of the genetic conditions, such as dense disease, they seem to have trouble with what are called endosomes, which live very close to the transporters in the brush border. And so those may be mutated, and the integrity of the endosomes is very important for proper reabsorption at the brush border level. If we look at lysosome problems, cystinosis is an inherited autosomal recessive disease in which cysteine is reabsorbed but not broken down. And the cysteine crystals accumulate in lysosomes and destroy the cells. And the same thing happens in light chain proximal tubulopathy associated with MGRS, that the lysosomes become overwhelmed with light chains. When we think about tenofovir as a cause of Fanconi syndrome, it's thought to have a direct poisoning effect on mitochondrial function. And finally, heavy metals poison the sodium potassium ATPase, which is really the currency of the proximal tubule. Without sodium potassium ATPase, the proximal tubule can't possibly do its work. So I just want to take a brief break, and those of you, the minority of the division who are not dog people can kind of shut off their phone or look at their text messages. But I was always curious about whether these things happen in dogs. And it turns out that the Basenji breed is a breed of dogs in which 10% develop Fanconi syndrome and significant chronic kidney disease. And depending on which veterinarian scientific site you look at, the current cause is thought to be an inactivating mutation in what's called FAN1, which is a gene which codes for transporters, and it seems to make the proximal tubule more sensitive to heavy metals. And that's been reported to be an explanation for why only 10% of these dogs, probably the ones that are more exposed to heavy metals, get Fanconi syndrome. This is also just a warning from an FDA report in 2018. At that point, there had been basically an outbreak of kidney disease among dogs who were using chicken jerky, many of which was imported from overseas countries. And the study reported that dogs fed jerky treats are developing Fanconi-like syndrome, which is a kidney function disorder. To date, the FDA has received around 5,200 complaints of illnesses associated with chicken, duck, or sweet potato jerky. The reports involve more than 6,200 dogs, 26 cats. I thought this was interesting, 3 people. And more than 1,140 dogs had died. And so, so just to be aware, if you have old chicken jerky sitting around your house, you might not want to give that to your dog. Getting back to our patient, we knew that since he was 54 years old, it was very unlikely that he had a genetic condition accounting for his Fanconi syndrome. And so we went through the various acquired causes of Fanconi syndrome. He had no history of lead exposure. We did send a lead level, which is really a very inferior way to look for lead exposure since most lead builds up in bone, but we felt that that was probably good enough. We did look back and it appeared that he had been on Tenofovir since 2009, which meant that he was on it for essentially 9 years until several weeks ago when it had been stopped when the renal referral was sent. And we sent an SPEP, which showed no monoclonal spike. He had a slightly elevated kappa lambda, which on repeat was 2. And so we kind of looked at that and we hemmed and hawed and we couldn't decide what to do. So we decided to really look at the literature. And we looked at the literature looking at light chains associated with Fanconi syndrome. And we learned that they were a distinct class of light chains. So they were almost always kappa. It turns out that the light chains that cause Fanconi syndrome have specific variable regions that are resistant to degradation by lysosomal enzymes. And you're probably familiar with those enzymes like trypsin and pepsin. And I think that they're in WD-40, but it turns out these light chains are pretty resistant. And the way that the proximal tubules are hurt, or that the light chains get in, they crystallize and cause dysfunction. And this is a relatively old EM showing light chain crystallization inside proximal tubules. We were pleased at that time to find that just in 2016, Vivette Degati and her group at Columbia had published the largest series of patients with light chain proximal tubulopathy, which was 54 cases, which they collected between 2000 and 2014. And those cases comprise 5% of all biopsies from patients with dysproteinuric kidney diseases. So a minority, but a sizable number. Interestingly, it was the first manifestation of dysproteinemia in 85% of these patients. So 85% of the 5%. This was their first presentation. 21 had MGRS, 15 had frank myeloma, 7 smoldering myeloma, and 2 non-Hodgkin's lymphoma. The other thing that surprised me was that 83% of them had significant kidney disease and only 38% had full Fanconi syndrome. Whereas I always thought people with proximal tubulopathy had more tubular Fanconi syndrome, but not as much renal failure per se, but renal failure was really prevalent. The other interesting thing after they did more careful pathology was they found there were actually 2 different types of light chain proximal tubulopathy. So there were those light chains that tended to precipitate in a crystalline fashion, and they encompassed 87%. And you can see this beautiful picture from that paper showing actually within the proximal tubule cells, you can see the crystals themselves of various shapes. But 13% of patients actually had light chain tubulopathy without crystalline structure. And so you can see these are not very happy proximal tubules. They're very vacuolated, but they don't actually contain crystals. And among these patients, kappa or lambda light chains were found, whereas those who had crystalline deposition all had kappa light chains. All had kappa light chains. So we look back to our patient, he did have an elevated kappa slightly, he did have Fanconi syndrome, and we thought, well, should we do a kidney biopsy? And if I were in a room with you, I would ask everyone to raise their hand if they wanted to do a kidney biopsy, and it would all be fun, but I'm not in a room with you. And so maybe if you can just, raise your hand on the screen, who would like to do a kidney biopsy? Nobody wants a kidney biopsy. All right, well, we did a kidney biopsy anyway, and we just really didn't want to miss anything. And what we found, we also felt that his creatinine of 1.05, with his being basically about 50 kilos with no muscle mass, could be representative of some significant decrement in GFR. So we did a kidney biopsy. It was pretty unremarkable. It just showed focal global glomerular sclerosis. The comment said there was no evidence for MGRS. There was mild tubular atrophy and interstitial fibrosis and mild arterial sclerosis. And at that point, we were pretty satisfied that this was drug-induced Fanconi syndrome. So what do we know about drug-induced Fanconi syndrome? I think I'm probably just going to rush through the last few slides because I see that I'm about to be over, but this is This is a list of drugs that have been associated with Fanconi syndrome, namely aminoglycosides, ifosfamides, cidofovir, and adefovir, which are not used that much anymore, tenofovir, old tetracycline, and a lot of those reports were actually in doctors' households who had old tetracycline on their shelf, and their families developed Fanconi syndrome, Suriname, and antiparasitic, and alcohol. If we look specifically at tenofovir, Mike mentioned earlier, he was looking at the organic anion transporters. Many drugs are secreted through the organic anion transporters, and from there across very strangely named pumps. This one is the multi-drug resistant protein into the tubular lumen. And the current thinking is that tenofovir inhibits mitochondrial DNA synthesis and upsets the energy source of the proximal tubule. And the very classic finding on EM are these atypical and giant mitochondria with their crystals sort of all in disarray. Do we know if tenofovir is nephrotoxic? Subclinical tubular defects were described repeatedly. Fanconi syndrome has been replied. Reversible ATN has been described. What's been harder to ferret out is whether tenofovir actually causes chronic kidney disease. The early randomized control studies show no. Industry-sponsored studies show no. Observational trials have suggested yes, although it's really quite rare. And to much excitement, tenofovir alefenide was brought out in 2016. It was a new prodrug of tenofovir, and I'm just going to show what's good about tenofovir alefenide is that you can give 300 milligrams of it. This generates quite a lot of tenofovir, these blue dots. Blue dots are tenofovir. Tenofovir disoproxyl fumarate is given. Lots of tenofovir in the plasma. Very little gets into the HIV target cell. Whereas when we give the new tenofovir formulation, we can give just a small dose of 25 milligrams. It goes right into the cell to fight HIV. Very little is in the plasma to cause kidney harm. So TAF versus tenofovir disoproxyl fumarate has been looked at in the 3 major indications for these medications, including HIV, Hep B, and very importantly, pre-exposure prophylaxis as well. I think I'm just going to I have 3 studies. I'm just going to go to the summary, which is that there's very little good long-term TDF data in adult patients. It's quite surprising. There are no good studies looking at whether TDF is in fact nephrotoxic over things like 10 years and 20 years. We do know overall that less than 1% of patients stop TDF for renal events. We do know that patients on TDF versus TAF have very small increases in tubular proteinuria and drops in GFR of about 2 to 4 cc's per minute when compared to patients on TAF. But again, it's not really clear whether that's clinically significant. The other thing that makes these studies difficult to sort out is that cobicistat, which is used in many studies comparing the drugs, blocks creatinine secretion. So it blocks the MRP channels on the tubular side. And so that increases creatinine in both TAF and TDF patients. And another important point is that TDF lost its patent in 2017, and therefore at this time, insurance is refusing to cover a lot of patients for TAF unless they have significant kidney disease. So in terms of our case summary, our patient had osteomalacia due to prolonged and severe hypophosphatemia. His hypophosphatemia was due to Fanconi syndrome. His Fanconi syndrome was likely due to long-term use of tenofovir. So what do? Well, we stopped the tenofovir and he was given phosphorus supplements as well as vitamin D. And when I saw him recently, his bone pain is completely gone. His legs are quite a bit stronger and he can walk again. The strangest thing is that he is still requiring phosphorus supplements. So when I try to stop his phosphorus, he becomes hypophosphatemic and he still has normal glycemic glucosiuria. And I've gone through the literature. There are no cases of irreversible Fanconi syndrome from tenofovir disoproxyl fumarate. And so I do not really know why he still has Fanconi syndrome. 4 years after stopping the medication, and wondering what you all would do if there's anything further people would do to sort this out. And I apologize for not having more time to go over the last data.
Thank you, Leah. Really cool case. I remember seeing something like this early in my fellowship, and sad that it seems to have been going on for so long. Laura has a question in the chat. Do you want to just unmute and ask, Laura?
Oh, sure. Basically we had a patient on KLP this week with a AKI and a Billy more than 20. And so we were concerned for there's very high risk for bulimic nephropathy, and hepatology had started him on TAF for Hep B. And I was just wondering if you knew of anything that makes patients more susceptible to Fanconi from Tenofovir.
Yeah, I think so. So I'm just going to go back to the main thing that seems to be coming out is that boosting agents, which block the MRP channels like cobicistat, seem to increase nephrotoxicity because they cause more intracellular accumulation. So there's very little. Just going to show a couple of. Sorry, this is the TDF versus TAF on HBV. Surprisingly, this is the largest study looking at this in the Journal of Hepatology, about 1,300 patients. There were actually no cases of Fanconi syndrome and no drug discontinuation due to major adverse kidney events in either group. Okay, so this is how rare this is. It's really not common. The TDF patients had a drop in GFR that was slightly bigger than the TAF patients at 96 weeks. Laura, there's even debate about whether TAF gets into the kidney cells through the organic anion transporters. Currently, it's thought not to. And so I think it's very unlikely that TAF has any significant nephrotoxicity. So.
Leah, do you think the absence of mitochondrial abnormalities on EM weighs against tenofovir, or
Yeah.
is that
Well,
the negative predictive value not high?
Yeah, I don't know. We did the biopsy about, I'm trying to think how many, it was probably about almost 3 months after tenofovir had been stopped by the time we did the biopsy, but he still had very significant Fanconi syndrome. So I was definitely bothered by the fact that he didn't have any features of mitochondrial disease on EM or on light microscopy. And so, should we be looking for other causes of Fanconi syndrome in this man? So.
Just wondering if you might consider genetic testing or something for dense disease or something else.
Yeah. I think that probably at this point I should probably do that. So.
Really interesting case, and we could ask some more. I see Fanula unmuted, so maybe give you a chance. Unless Christine, I think your hand was raised to vote for biopsy, but if you have a question. Okay, so if people need to drop off, that's fine. But otherwise, Fanula, if you
just a quick comment about potential irreversibility after stopping the tenofovir. We've noticed it with topiramate-induced kidney stones that in a certain percentage of people, stopping the medication doesn't reverse, the tubular changes where we see this, finding of an RTA. It can persist indefinitely, even after stopping the medication, and it's unclear why. So I wonder if it's the same with tenofovir in some cases.
Interesting. So.
Well, thank you again, Dr. Haseley. Thanks to all the presenters. Really great talks today. And have a great weekend all.
Thanks, everyone.